first of all, thank you for coming. We very much appreciate you coming in to listen to our talk today on pacemakers and defibrillators, and I hope to educate you a little bit and hopefully answer any questions you may have as well about these devices, what they're used for, and the applicability to individuals, and any other questions about specific issues regarding them. I've been fortunate to really follow a major technological revolution in these devices since I began to implant them in the early 80s, and I've really watched a marvelous transition of the sophistication and what they can do, the advent of defibrillators, the miniaturization of the components, the change of the implant technique, the follow-up, the programmable parameters. They've really become amazing little devices that can do a great deal to regulate cardiac rhythm and save lives in the terms of the defibrillators. What I would like to do at first, without hopefully getting too technical, is to talk about what makes up a pacemaker. What is it? And we'll just kind of look at the components, what they're made of, how they function. We'll talk a little bit about the implant technique, how we actually place these in the body, a little bit about how they're followed up, and then of course the indications, who needs a pacemaker, for what symptoms and what medical problems, cardiac rhythm disorders, and then lastly a little bit about defibrillators as well. So let's kind of look here and see. A pacemaker system is comprised basically of two major components. You have the battery pack, which is called the pulse generator, and we're going to look at this, the individual components within this in just a moment, and one or more lead wires, which are insulated wires that connect to the brain or the battery pack and run to the interior surface of the heart, where they can sense the heart rhythm and also pace the heart. And or defibrillate it. Yes, ma'am.
Are you on a microphone and you can turn up a little bit? I can't hardly hear you.
You can't hear me? Uh-oh, I need to speak up then. I don't think, yeah, I think these days I think we go directly to Facebook and and YouTube. My voice doesn't carry very well, so I'll do the best I can. But we were talking a little bit about what comprises a pacemaker. And the battery pack here is composed of a series of batteries and microprocessors, and I'll look at that in detail in just a moment, and one or more lead wires that are inserted into the interior surface of the heart and are responsible for both sensing cardiac activity as well as pacing the heart, and in the case of a defibrillator, shocking it back to normal rhythm. Now, we talked, we were looking at the battery pack here, which is called the pulse generator, and about half of the battery, pulse generator is composed of microcircuitry. These are little computer chips. So your pacemaker defibrillator is basically a small computer that can sense the heart rhythm and is very programmable with multiple different parameters. And then the other major component are the lithium iodide batteries that enables these devices to have a very good longevity. That's why they can last 8-10 years because of the type of batteries that are present. When we change a battery, we don't actually cut the metal of the device open and put a new battery like you would a home device. We have to insert the entire pulse generator, because you wouldn't want any body fluids to leak into these things. So they're sealed to prevent body fluids from leaking in and shorting out the device. This is a little bit more dissected view here, and as I was talking about, these little microchips enable the miniaturization of the devices. When they first came out, they were more like this. So you can see the difference in the size of these pacemakers from the 1960s when they were first invented to now. And the microchip has enabled this in large measure. We used to have to put these in the abdomen, and now, of course, they can be implanted under the collarbone. As I said, most pacemakers have 1 or 2 wires that are inserted into the interior surface of the heart. This is the little diagram, and on a real chest X-ray, you can see where the wires are connected to the generator and then travel through the veins down into the heart. And we take X-rays after we place a pacemaker specifically to make sure that they're in the proper location. And this is just pointing out where the lead wires are. Now, for many years, all we had available was a single wire that was inserted into the right ventricle, which is the main pumping chamber that pumps blood to your lung. And this works very well for patients with atrial fibrillation and certain other slow types of heartbeat, but it did not exactly mimic what Mother Nature does, which is a communication between the top and the bottom. So subsequently, a dual chamber pacemaker became the state of the art for most patients that need a pacemaker for slow heartbeat. And these type of pacemakers enable the 2 wires to talk to each other so that they can more closely mimic what Mother Nature does, where the top part of the heart beats and then the bottom part in perfect synchrony back and forth. This was a major advance because it was much more physiologic, much better at helping the heart pump normally. And this is just a representation. When we can basically tell if the pacemaker is working fine just by analyzing the EKG. And this EKG, I wouldn't expect you to know how to interpret it, but it shows perfect function. And that's all you really need in most cases to be assured immediately whether your pacemaker is working correctly. This is just another X-ray to show that nowadays we also have a third potential wire that can be added in certain heart failure patients. So nowadays, in addition to treating slow heart rate and other heart rhythms, some of the newer pacemakers can actually physically help the heart to pump better. And that's the function of this third wire. It's got a big long name. It's called cardiac resynchronization therapy. But as I said, not only does it prevent the heart from going too slow, but it can physically actually help that heart to squeeze more blood, which has yet again been another major advance in pacemaker technology. Well, we were saying that the little lead wires conduct electricity from the battery pack to the interior surface of the heart, and that what makes the heart fire and contract. They also sense the heartbeat. So, for example, if we set a pacemaker at, say, 60 beats a minute, if your own heart rate is above that, the pacemaker will shut off. It will not pace. It will allow your heart to beat above what we set it at. But if your heart rate was to fall below that, then the pacemaker would kick on. And the way that that's able to do it is because it senses the electrical impulses from the interior surface of the heart and relays them back to the brain of the pacemaker that we looked at a minute ago. Now, these little wires, what are they made out of? Well, they're made out of coils of stainless steel that are insulated. You would have to have an insulation on a wire just like you would for a home appliance or anything else. And years ago, all we had was one coil here, it's called a unipolar lead. In later years, we have what's called a bipolar lead, which is a coil within a coil. And each coil is insulated by a material that is either usually silicone or polyurethane. So the wires have a coating on them, and then they're in electrical contact with the heart muscle. The older style pacemakers years ago would actually sense the heart by recording electrical potentials between here and the actual can of the pacemaker. So that's why in an older pacemaker years ago, a microwave oven, for example, could interfere with it because the antenna for the sensing of the pacemaker was very wide, all the way from where the wire goes in to where the battery pack is. But in later years, and that's just a representation, in later years we now use what's called a bipolar lead, which means that the two little electrodes are totally within the heart. So they're much less susceptible to interference from appliances and generators and things like that.
Does the patient know when the battery goes dead?
Well, these days, what we do is we follow these devices, and when we interrogate them using the programmer, it will actually tell us how much battery life is left. Now, in rare cases, if somebody has not had good follow-up and the battery actually is totally depleted, then yes, they will no longer have pacemaker function. But as long as you're following up, we should definitely know when the indication is to replace the battery. The programmer will actually tell us how much life you have left on it. These little wires, I'm going to pass these around so you guys can kind of look at them and see. You can get a feel for how they feel. In the early pacemakers, we had a little flange that when we inserted the pacemaker, we just kind of wedged it down into the heart tissue. In later years, we developed electrodes that actually screw into the heart. So there's a small little barb or screw that's actually inserted, and it holds more tightly into the heart and more securely. I'm going to pass these around. Brandy, you can have people just take a look at them. And pass those around as well. Also, another major advance is that the little tip of the pacemaker wire that you have there is now coated these days with a steroid that prevents or it helps it heal faster. So that's been another major advance. As I said, it just helps it heal faster, and the electrical properties of the pacemaker that we get when we first put it in will be without change when we follow it up. Well, how do we put these in? And this is a little diagram to kind of show just a little animation. So we go under the collarbone here and locate a main vein and use a needle to puncture the subclavian vein. Once we get the vein punctured, we place a little guide wire. And this little guide wire actually travels down into the heart. And then we place what's called a sheath. And through this sheath, which has got a little diaphragm on it, we place the lead wire down into the heart. So it's actually coming up through the stick site, down through the valve, and then we begin to screw it in to the interior surface of the heart. Play that again. So some of our challenge sometimes is actually getting access, in other words, actually being able to stick that vein. And then we make our little incision here right under the collarbone, and that's where the battery pack will go down in here after we place the wire in the heart. And all this is done under X-ray when we're doing it. So that's how we're actually following that little wire down into the heart, is under the fluoroscopy of the X-ray machine. And you want to be sure you get it screwed in very securely, because nobody wants to have to come back and do it over again. This is just another depiction with a live model. Same kind of animation here, but there will be a live model heart coming up where you can actually see it in a beating heart. So this is an actual beating heart. It's probably more what it really looks like. We're placing a wire down through the valve. You can see the chordae tendineae, which are the strings of your heart. That's the valve. Here comes the wire. And once we get that inserted into the proper location, again, we screw it into place and hook it up. Now, One other thing that really fascinated me early on in my experience with pacemakers is we can do so much to program them. We can set the rate of the pacemaker. We can change that. We can change the output of the battery. We can enable many different programmable features.
Okay, well, I guess it goes back to the...
Yeah, you guys can just pass it around or bring it back to Brandy. But there are many, many things we can set by just using the programmer. We don't have to go back in and adjust it. It's all done through a radio frequency programmer. But many, many parameters can be adjusted to help the pacemaker function optimally. Another major advance is what we call rate responsive pacing. The old pacemakers, you just set them at a single rate. You set them at 60 or 70 and that's all they would do. The newer devices have a sensor in them. So they try to mimic more closely what Mother Nature would do, because if all of us start walking or exercising or running, our heart rate should go up. And the pacemaker will actually sense that and adjust your heart rate up to what would be more closely what Mother Nature would give us to start with. So it was nice because, particularly for younger patients, we could have the pacemaker adjust to the activity level of the patient.
Doctor, does the wires make any difference to the valve when you go through it?
Well, that's a good question. Yes, they actually do have to go down through the valve, and every once in a while we can get a little leakage through the valve because that valve has to close down every time your heart beats. Up and down, the valve is kind of tightening around the pacemaker wire. And it can cause a little leakage, Byron, but it's typically not serious, and it typically is very well tolerated. Damage to the heart valve from the pacemaker wire is very uncommon. I mean, it's a possibility, but it's very uncommon. Yes, sir?
Can you feel it working, or?
That's a good question. The amount of electricity that it takes to make the pacemaker actually make your heart beat is so small that most patients do not feel it at all. So the vast majority of patients will not be aware of when it's working. We can tell them by checking it, oh, your pacemaker's working 50%, 100%, but typically the patient will not feel it because you're only using a small percentage of under a volt. So it doesn't take much juice to make it work. And that's another reason the batteries make it last so long, because you've got it right down inside the heart tissue. Once the pacemaker is implanted, we follow it up with a little device that Brandy can pass around and show you. It used to be that you'd have to come to the office every 3 to 6 months, and we would have to actually physically put the programmer on, check the pacemaker. Nowadays we have what's called home monitoring or CareLink, and you can put this little handy device next to your bed and it'll read your pacemaker or defibrillator and transmit the data by cellular means to us, where we can analyze it and follow it up without you actually having to come in. So it really decreases the amount of physical time for follow-up of pacemakers these days. Well, we've talked a little bit about technical things, and I didn't want to get too technical, but these devices are in fact, you know, they do have quite a bit of technical specifications. But now let's talk a little bit more about, you know, who needs a pacemaker. Well, one of your basic indications for a pacemaker is when the little nerves on the inside of the heart begin to wear out. You're all aware of blockages in arteries of your heart. Well, your heart also has little nerve fibers. And these little nerve fibers run into the heart tissue, and there's actually what makes your heart beat. If you did not have these electrical nerve fibers firing, your heart would just lay there. It would never actually physically beat. And the little nerve fibers can calcify or become inflamed or just degenerate with aging process or other types of damage. And that's one of the most common indications for a pacemaker. This little bundle of cells up here is your own God-given pacemaker, and it normally fires, as we're sitting here talking, between about 60 and 100 times a minute. And these little impulses travel down to the bottom part of the heart through these little nerve fibers, and again, make your heart beat. And when there's an interruption in this, the heartbeat can become irregular, too slow, and cause the need for a pacemaker. Now, some of the symptoms that you may have with slow heartbeat, probably the most common would be fatigue, short of breath, feeling like you're going to pass out. We call that syncope. Dizziness, lightheadedness, effort intolerance, just can't do as much as you used to be able to do. Confusion, disorientation, chest pains, palpitations of the heart. So these are some of the more common symptoms that could indicate that your heart is beating too slow or irregularly, and again, could be an indication for a pacemaker. We can also tell in some cases just by looking at the EKG when the heart is way too slow or these impulses are being blocked from the top to the bottom part of the heart. So some patients will come into the emergency room feeling tired, fatigued, short of breath, and lo and behold, we do an EKG, and only every third heartbeat is making it down from the top to the bottom part of the heart. We call this complete heart block, and it's an absolute indication for a pacemaker. Another common indication for a pacemaker placement is atrial fibrillation. Atrial fibrillation is an irregular heartbeat originating in the top portions of the heart, where the top part of the heart and the bottom part of the heart are beating out of sync. The top part of the heart is just kind of quivering and beating very rapidly. But one of the problems you can get into with atrial fibrillation is that many times the patient will come with palpitations or shortness of breath, and you have to use medication to slow that heart rate down. And then once you use the medications to slow the heart rate, it can go too slow. And we get into this thing called tachybrady syndrome, which is where the heart is too fast, too slow, too fast, too slow. And a pacemaker can take care of the slow heartbeat and then used with medications that will prevent the heart from racing too fast. So it can very nicely straighten out the heartbeat in some patients with atrial fibrillation. Now, not everybody with AFib needs a pacemaker, but some patients do, particularly if their heart is oscillating, just way too much between fast and slow heartbeats. Now, some of the symptoms of atrial fibrillation can be palpitations, a feeling of the heart quivering, beating irregularly, pounding in the chest. Some patients will describe their heart as racing, chest pain, shortness of breath is very common. Fatigue, we talked about just not being able to do as much exercise or physical activity. Occasionally chest pain. Some patients have absolutely no symptoms with atrial fibrillation. It's just discovered when they come to the doctor, their pulse is irregular, we do an EKG, and they have AFib. So again, not every patient with AFib needs a pacemaker, some do. And of course your doctor can determine that. Pacemakers are wonderful little devices. They enable many patients to have a much improved quality of life. Some can be life savings, but they're not perfect because God did not make them. They're man-made devices, they're machines. So they do have some liabilities, some complications, some problems. And that's why, not our cardiologists actually implant these devices, and some of us do, because you do have to have kind of special attention to being able to troubleshoot them. And we can kind of start from the implant procedure, and as you may remember from that video, we go right here, and when we're placing it, we insert a needle right under the collarbone, right on this vein. And that's how we actually get the little lead wire to go to the heart. A lot of patients will say, well, doc, how do you get that wire in my heart? Well, that's what we do. We use a needle and go under the collarbone and puncture this vein. Well, the lungs are right here. And it's occasionally you can have a little injury to the lung tissue when you're actually placing the device. It's not common. It's called a pneumothorax, but you can get a little air introduced into the lung if the needle was to puncture right there instead of right there or right there. Not a terrible complication, but it's something to be aware of. And that's why we check a chest x-ray. Those of you who've had devices placed, you know that we check a chest x-ray and we can see where the wires are. We can also see if there's been any damage to the lung tissue. So before a patient goes home the next day, we check the chest x-ray. There can also be damage to the vein because occasionally the wires will actually cause the vein to kind of scar down and close off. Generally that's well tolerated, generally not a serious problem, but it is something that occasionally we see. Well, as you may remember, these little wires go right under your collarbone, and you can imagine as we're all sitting here talking and the heart is beating, that wire is flexing. And over the course of the day, you know, this wire may flex 14,000 times or so during the course of the day and right under your collarbone. So occasionally you can get a break in the wire from that. And it's called subclavian crush because it's kind of squeezed between the collarbone and the rib. If that occurs, sometimes you have to replace the wire. And you can see where fracture of the wire is a possibility. Now again, this stuff is not common, but it's just something that you should be aware of. And we can tell sometimes about a break on a chest x-ray, or when we interrogate the device, we can tell by the readings if there's a break in the wire. The wires can pull loose despite our best efforts. It should be way down here in the heart. In this particular one, it's pulled way up. Sometimes that occurs despite our best efforts. It may be because, you know, the patient did a little bit too much with arm motion, and there are some times where it just the heart tissue is not as strong as it should be. Occasionally, some patients will not really kind of be aware of this, but can actually manipulate the device. In other words, twist it or turn it, and many times the patients can do it when they're not aware of it, and it can result in what we call twiddler syndrome, where the wires become all twisted up and dislocated, and we have to go in and replace it. Uncommon, but it's something that we do see. And I guess the most feared problem with pacemakers would be infection. It's not common, but when it does occur, it can be very serious because with any prosthetic material, it can be hard to get rid of the infection, and sometimes we have to take the whole device out. Now again, this is not common, but if it does occur, it can be a serious problem that may even require removal of the device. And then one thing I will mention briefly, in today's environment, interference with pacemaker function is uncommon, but it can occur, for example, during surgery. If electrocautery is used close to the pacemaker, it can inhibit it. So many times if you're having a surgical procedure, they'll put a magnet over the pacemaker to force it to pace and not let it be interfered with the little cautery device. Lithotripsers, rarely. Some patients that have cancers of the head and neck or lung or breast that need radiation therapy for the treatment of cancer, radiation can damage the device, therapeutic radiation. And sometimes we have to move it to allow a proper window for the treatment of certain cancerous conditions. MRIs, it used to be that if you had a pacemaker you couldn't have an MRI. Nowadays we have a whole family of devices, and I never thought I would see this in my career, that are actually MRI compatible. But you have to have the proper leads and the proper device, which have really just been out for over the last several years, and it does require some programming, but the newer devices have enabled many patients now to have an MRI. If you've had your pacemaker in for years and years, sometimes they're not yet compatible because the wires have to be the proper compatibility as well as the generator. And if your card will actually tell you if your pacemaker is MRI compatible. Medtronic, for example, is one major manufacturer of the devices, and I think all of their devices, their pacemakers, defibrillators, are now MRI compatible, and many of the other manufacturers have similar capabilities as well. But so I'd like to move on for a minute and talk about defibrillators. Nowadays, when you get a defibrillator, there's a pacemaker actually placed in the defibrillator as well. Back in the 80s, we actually used to have to place two of them, and we would put a defibrillator on one side and a pacemaker on the other, and they didn't talk to each other, and it was really a major problem. So another major technological advance is that in today's cardioverter defibrillators, the pacemaker is built in and works automatically in conjunction, perfect sync with the defibrillator device, which has been an amazing advance, actually. Well, who needs a defibrillator? Well, let's talk for a minute about the indications. Cardiac arrest is caused by a condition called ventricular fibrillation. And what that means is that the heart basically has gone into a state where it's just quivering. The heart rate is so fast and so disorganized that the heart is not actually pumping in a coordinated fashion. It's just laying there quivering. And of course, this is a fatal condition unless treated promptly. So how significant of a problem is this? Well, it's very significant. You can't see this, unfortunately, but this is a little slide showing causes of death, sudden cardiac death in the United States. And that's this bar. And I'm sorry that the actual numbers don't show, but, and again, I apologize for this slide, but for example, here is lung cancer, here is stroke, here is, I think, breast cancer, and this is AIDS. So HIV, certain types of cancers, these are deaths here. Look at the cardiac deaths, much, much more. So you're much more likely, whether you're male, female, and to some degree, young or old, to die of heart-related causes rather than cancer. Many women fear breast cancer, but it's much more common to have a cardiac-related mortality. Also, if you have a cardiac arrest out of the hospital, you're kind of in big trouble because the survival after a cardiac arrest is directly related to the time that passes before the heart is shocked back with a defibrillator. And you can see that within 10 minutes or so, your chances of actually surviving a cardiac arrest go down to less than 10%. So that's another issue that we're dealing with. Now, this is kind of what your doctor goes through to determine who needs a defibrillator. This is kind of our thought process. And what it boils down to is that we're concerned about anybody that has a weakened heart, whether it's from congestive heart failure, previous heart attacks, bypass surgery, but a damaged, weakened heart muscle places you at higher risk of dying suddenly, even if you feel great, even if you take your medications, even if you have no symptoms. So that's the patient population we're most concerned about. That's what all these numbers mean. And there are other technological, issues and considerations, but we're concerned particularly about patients with heart failure, blocked arteries, previous heart attacks, and weakened hearts. And there's some additional testing that can be done, but this is the patient population that is at greatest risk of sudden cardiac death and that can benefit the most from a defibrillator implantation. The defibrillator, of course, works automatically. I kind of like to think of it like an airbag in your car. You may never need it, but if you do, it has to work immediately, effectively, and without anybody thinking about it or doing anything, and it can flat out save your life. those are the primary indications for defibrillator implant. Two majors: somebody that's actually suffered a cardiac arrest, no question, and the other people at risk, as we discussed, may also benefit from it. And of course, your cardiologist can tell you about what your risk is and if you would benefit. So those are some of the things I kind of wanted to go over. I know it's been a little bit technically oriented in terms of our talk, but I thought I'd kind of like to open it up a little sooner than later for questions, and we can talk a little bit more about you know, any specific details of the devices.
You mentioned you control the wires with if you raise your hand too high. Are you limited when you have a pacemaker?
Shortly after implant, remember how we were showing the little lead wires? Well, the little screw that's on the bottom of the lead wire that we place into the heart, until it has a chance to actually kind of scar into the heart, it's more susceptible to being pulled back, because this little screw, I'm gonna actually rotate this out and pass it around. It's very small, so it just has a small amount of heart tissue. But the direct answer to your question is, there's a risk of that for the first maybe 6 weeks or so, while the lead is actually scarring securely into the heart. After that, it's much less of an issue. So when you first get it put in, we have the patients take it easy with their left arm, not a lot of physical activity, unless you're left-handed, and then we put it on the right side, and it would be a similar thing with the right arm. But once you've had it in for a period of time, it's uncommon for the wire to come loose.